Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about autoimmune diseases and its associated abnormalities. In particular, I was talking about a condition called leukopenia, namely low white blood cell count. That's what I've done several shows about the last few shows. When I left off, I was talking about the value and the meaning of white blood cell count. You cannot survive the environment that we live in without having a proper quantity of white blood cell count of different types to help fight the infections that we exposed to, namely the bacterial infection, the viral infection, the fungal infection, etc. Very, very crucial. So that's why we have different types of white blood cell. We have the segmented polys, we have the band, we have the lymphocyte, we have the monocyte, we have the eosinophil. And in our circulation, we have the total white blood cell count is between 5,000 to 10,000. That's important. But you also have to understand, besides the total white blood cell count, we do something we call a differential count under the microscope, or now it's being done partly by the computer as well, whereby we could tell how many segmented polys there are, how many lymphocytes there are, how many monocytes there are, how many eosinophils there are, how many bands there are. These are the common ones we see in the circulation, okay? And all these blood cells are studied out in the bone marrow. The cells that produce them are in the bone marrow, okay? And once they get produced, they get dumped all day long, all night long into the circulation. And then because they died out after so many days, and the new one has to come in. In addition to the blood cells that are in the circulations, we have white blood cell in the lining of our blood vessel, sitting there, waiting to be called into action in the event they are needed for an infection. Or else they get mature. As they get mature, they get dumped into the circulation. As they get dumped into the circulation, after X number of days, they died out and new ones are coming in. That's what we need. Without that, we don't have a chance of surviving. We would have been eaten away literally by things that are in the environment that we eat, we breathe, we come in contact with in our skin, etc., etc. Okay? We come in contact with other people that are contaminated. We shake hands with them. They can contaminate us that way. We go to the bathroom, we use the bathroom, we forget to wash our hands, we touch the doorknob, we can get contaminated that way, so on and so forth. So that's crucial. However, there are ethnic reasons why some of us have lower white count than others. The subgroup with the lowest white count due to ethnicity are Negroes. And I use the word Negroes for a good reason, because in this country, it started out in the early 60s. When I was here, we were Negroes, and all of a sudden, the civil rights movement started, which was a great thing, and the word black, African American came into the vocabularies. The truth is, we are Negroes. And it's very important that we pay close attention to that, because there are more Negroes in the world than any other woman group, subgroup alive. Some of them want to call themselves Negroes. Some of them don't want to call themselves Negroes for social, political reason, whatever. But we know they are Negroes. We don't even have to test them, because we could look at them, so they are Negroes, okay? You can be a dark-skinned person, don't be a Negro. Even if you are mulatto, you are a Negro, okay? But that's their problem. They have the right to it. Who am I to tell people who to call themselves or what to call themselves? Suffice to say, medically, that is crucial. Because when you are providing medical care for an individual, the ethnicity of the individual is crucial. Because different ethnic groups get afflicted by different diseases more often than others. Different ethnic groups get afflicted by diseases that they inherited more frequently than others, and so on and so forth. And on top of that, the symptoms are different. The way they present are different. Different people present with different symptoms. Believe it or not, there are ethnicity associated with symptomatology. There are people who constantly having headache, constantly having belly pain, constantly having cough, constantly having aches pain. That's the symptom they present with. You have got to evaluate them, but you also have to understand this is their right, but that's who they are. And that's never going to change. On top of that, if you don't know the ethnicity, you don't comprehend their ethnicity, you're not sensitive to it, how are you going to evaluate them properly to provide proper medical care for them? The white blood cell count story is a perfect example. A study was done at Columbia University School of Public Health. They found out that 25% of what they call black folks in those days in this country have low white blood cell count. 25% across. That's a lot. Okay, and I'm here to tell you that I have a lot of Caribbean people in my practice. The median white blood cell count and Negro people from the Caribbean is 2.6 million. And I have a lot of other people who call themselves African American, which is fine, that's their right. I have people in my office walking out with white blood cell 1,500. I have people that I've been taking care of almost 40 years. But you know that they have it. What do? You have to evaluate them completely and thoroughly, because there are many diseases that may be responsible for the low white blood cell count. After you exhaust everything, then and only then do you have the right to conclude that they have the low white count because of their ethnicity. Because they can be a Negro person, also have rheumatoid arthritis. They can be a Negro person, have lupus. They can be a Negro person, have scleroderma. There can be a Negro person, have sarcoidosis, and so on and so forth. And all these conditions can cause them, in addition to the possibility of the white count being low because of their ethnicity, because they have these things on top of it. Dermatomyositis, so on and so forth, okay? Systemic sclerosis, overload syndrome, on and on and on and on. So this is crucial. Now, that as you keep that in mind, you know the facts, then you have to evaluate them. We went through the evaluation. We went through the examination. We did all the physical exam. We look at the skin, looking for a rash of different type. You can look for alopecia, areata, local alopecia. We look at all these things. We look at the fingernail. We look at everything. We look at the mouth, the eye, because there is no organ in the human body that has not been known to be associated with autoimmune disease at one time or another. I copied the other day. I just told you, I copied the other day before I came here, 10 pages, single line of different types of autoimmune diseases across the world, across this country. There is no single organ that has ever been, that was created by God, that has not been known to be affected by autoimmune disease at one time or another. So the best way to evaluate you go by organ. You look at the skin first, okay? Then you go look at the brain, look at the eye, the mouth, and you go on from there all the way down. So when you're examining the person, you pay close attention to all these things. In addition to that, if you suspect the person have some sort of rheumatological diseases in addition to that's causing them that, then you do a complete evaluation of that. You do a complete blood count. You do a differential count is crucial. What do the platelets look like? Are they atypical? How many monocytes they have? What do they look like? And so on and so forth. How many eosinophils they have? And so on and so forth. That's crucial, okay? Because then you go on, what's the platelet count look like? Okay. Now, you look at the complete chemistry profile. What does the blood sugar look like? Take a look at the kidney profile, the electrolytes. Take a look at the liver profiles. What do they look like? Are they normal? Are they abnormal? And so on and so forth. You look at all this stuff. Then you go back. You must do a sedate. You must do an ANA. You must do a rheumatoid factor. And depending on what your level of experience is and what it is that you suspected, the whole list of other fancy tests that are not used frequently, that I will not bore you with, that I have here in the form that I have more than 200 blood tests that you could use. You click those off to see if that's what the problem might be, okay? Then now that you do that, you must also remember to do an HIV test. Why so? Well, when a presenting symptom or finding in somebody who's infected with HIV could be low white blood cell. How about that? So you have to do all that stuff. Of course, when you're talking about HIV, you got to get consent from the patient to draw the blood. So you explain to them why you're doing it and so on and so forth. So you do all that stuff. Then remember, while you're examining the patient, you also pay close attention not only to the liver, to the spleen, because you're talking about rheumatoid arthritis, the patient might have Felty syndrome. Because rheumatoid arthritis can be associated with a condition called Felty syndrome, whereby the spleen is enlarged. And once you have an enlarged spleen, then all bets are off. Because once your spleen is enlarged, then you're likely to have low platelet, low white cell, low red blood cell. Because of portal hypertension, the spleen is sucking these things up. Or it may not be Felty at all. It may be just one other autoimmune disease that it can cause your platelet to go up. I mean, your white blood calcium to go down. Why are you doing a thyroid profile? Well, you're doing a thyroid profile because there are several autoimmune thyroid diseases, such as Hashimoto's, for example, that can be associated with low white blood cell count because Hashimoto is an autoimmune thyroid disease, and so on and so forth. So that's why you have to pay close attention to the thyroid. You do a thyroid profile, etc. You got to be thorough. You know, you have to understand, when you are practicing clinical medicine, particularly in this day and age, you may have one possibility to miss a diagnosis on the patient. You may not see that patient again. You may not. But you had an opportunity based on what the patient tells you, and you miss that opportunity. The patient wind up somewhere else. The next thing you know, you're being blamed for missing a diagnosis. You don't want that to happen to you. So you be thorough. If you agree to take care of this patient, it has nothing to do with perfection. This is the way things ought to be done. Because you may not see that patient again. And you don't know why the patient was in your office to begin with. I mean, in my case, I don't take new patients anymore, so which is fine. But when I used to, some patients came to my office, they were there for a particular reason, or they were sent there for a particular reason. I couldn't care less because I have a specific type of way that I do things, and I don't vary that. I have a way I do things when I'm seeing a patient for the first time. If it is a complete exam, if I'm seeing a patient just because they have a cold or a bronchitis or urinary tract infection, there's a specific way I can guarantee you. And there's a specific way I do which patient is in front of me. Is it a female? If it's a male? If it's a Negro patient, Hispanic patient, a Caucasian patient, and where that Caucasian patient comes from. Is the patient from Greece? Is the patient from Italy? All these things are crucial, okay? Or the patient from the Caribbean. Where the patient from Africa. Because this patient is going to present to you nowadays, in particular, when you have people travel on Monday they're in Africa, on Tuesday they're in New York City, and they can bring these different conditions with them. Let me give you a classic example of what I'm talking about. There's a condition called H. pylori. Okay, well, 50%. Let me repeat that: 50% of the world population is infected by H. pylori. 50% of the world population is infected by H. pylori, which is a microorganism that get infected through you eating something that was not properly cleaned, come in contact with some fecal material, and you eat that. That's how you get, it's got to be from fecal material to mouth, 50%. It's a nosocomial infection. In this country, 30% of the U.S. population is infected with H. pylori. How about New York City? 70% of New York City population is infected with H. pylori. How about that? Why? Because you have people from New York City, a fantastic city that did a lot for me, that helped me to get where I am, by allowing me to go to high school at night and go to college at night, etc. Fantastic city. But 70% infected with H. pylori, whether they know it or not. But you have to know the symptom of H. pylori. So that when the patient comes to you, so that you know where they come from. They went on vacation. Where did they go on the vacation? And so on and so forth. All these things you have to pay close. There's a way of doing things. Remember, you may never see that patient again, as well as you might. But if you miss it, you know what? You were involved in the care of that patient. The patient is going to say or not say, I was at Dr. So-and-so. I did tell Dr. So-and-so about that. How come Dr. So-and-so didn't do anything about it? Okay? So you got to be careful. Don't be in a rush. I got a text from my office a couple of months ago. Somebody looking for a job. Somebody was a nurse practitioner or a PA or whatever. This person pitch to get the job was the fact that she can see 36 patients per day. Now, let me repeat that. The pitch that I get and the CV that I received, there was a notation that this patient can see 36 patients per day. Now, give me a break. How in the world somebody going to see 36 patients a day and provide quality care for them? How? It's not going to happen. But that was the pitch that was being made to me for somebody who's looking for a job. So that was a negative right there. Okay? So, I mean, give me a break, all right? So now then, you've done all your exam, you do all this stuff, and those are pretty much routine stuff, okay? You have to know the meaning. Why are you doing a SED rate? Well, you're doing a SED rate because all autoimmune diseases are inflammatory in nature. And all chronic inflammatory diseases have elevated SED rate. You can't have, because the inflammatory in nature. Once your SED rate is elevated, right away that raises a red flag. You have a responsibility to find out why is this SED rate elevated. Then you must troubleshoot it to find out the different things that can cause your SED rate to become elevated. Then you do an ANA. The ANA comes back abnormal. Well, then you got to break it down. You got to do an ANA to find out why is this ANA elevated, because there's several diseases that can cause your ANA to become elevated. So that broad screening test that you have to do, it's really not that difficult. The knowledge is difficult, but it takes years to gather the knowledge. And you can't just gather knowledge by seeing 36 patients a day. It's ridiculous. That's quantity, that's not quality. There's no way anybody can tell you they can provide quality care in doing that. So now then you do that. If you diagnose a specific autoimmune disease, you're going to treat that autoimmune disease. But while I'm talking about this is not about it, it's about the low white blood cell. Now let's take some time to treat the low white blood cell. What do you do? If the patient is minding his or her own business, they're asymptomatic, just tell them to be cautious, and so on and so forth. You keep that in mind. You tell them the do's and the don't. And this patient, when he or she has a bronchitis, you have to be more aggressive because the patient have a low white count to begin with. You can't do anything about it. Well, first of all, there's certain, if it's a flu, you could step in and give the medication, Tamiflu, blah, 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 all the rest of it. But if the patients have underlying disease such as asthma and or COPD or other chronic pulmonary disease, you must add an antibiotic. Why? Because the viral infection is going to cause an inflammation to develop throughout the pulmonary system. That inflammation then renders the heretofore quiet lining of your pulmonary system to no longer be quiet. They become inflamed. Therefore, the local infection, all of us carry bacteria in our nose, bacteria in our throat, bacteria in our mouth. I want you to understand that the bacterial flora in the nose is different from the bacterial flora in the mouth. The mouth is sitting right next to the throat, and yet the bacterial flora in the throat is different. There are different types of bacteria in your throat and there are different type of bacteria in your mouth. There are different type of bacteria in your nose. That's right. So therefore, when the person is coughing and is sick, you have to know what broad spectrum antibiotic you're going to use that's going to cover the nose, cover the mouth, and cover the throat. And for that matter, cover the lungs. That's exactly, if you don't know, that is your problem. I hate to be rough about it, but that is your problem. You went to medical school. I'm not the only one who knows this stuff. You should have learned it so that you know what to do and what not to do. You can't give everybody who has a cold antibiotic. But somebody who has asthma is not everybody. Somebody who has COPD is not everybody. Only they have underlying pulmonary disease, and they also have low white blood cell count. How about that? So you may be much more aggressive, and you must know the different types of broad spectrum antibiotic that you must give them in order to prevent them from developing pneumonia. That can lead to a pneumonia, but if you're proactive, you know your patient, he or she calls you on the telephone, they don't have a fever, you decided you don't have to bring them to examine over the chest x-ray, but there's stuff you could do to be more aggressive. Your patient has low white blood cell count, okay? And he or she develop a urinary tract infection. Then you could then in this setting, you culture the urine so that you know specifically, once the urine is cultured, then you must know what type of antibiotic you could provide for somebody who has chronic leukopenia, who now has an infection in the urine. What antibiotic you're going to use, you must be super aggressive. The person has a prostate infection, prostatitis. You could tell clinically the patient has prostatitis based on the history. You're not going to go in there, examine that prostate. That would be stupid, because if somebody has prostatitis, the last thing you want to do is to put your finger on that prostate gland. If you do that, you're going to spread the infection. But you must know enough to know this is prostatitis based on the history that I'm getting. And then the patient already have leukopenia. What am I going to do about it? What antibiotic I'm going to... You have to know what types of antibiotic that's going to be most effective, broad spectrum enough that's going to cover any and all possible antibiotic that can cause that. If the patient is sexually active and they're having prostatitis, then you have to think that they may have chlamydia, they may have gonorrhea that's causing the prostatitis. If they're not sexually active, they're an older individual, they have prostatitis, the series of things that can cause that prostate to become infected is different. It's not going to be chlamydia. It's not going to be gonorrhea. It's going to be something else. So therefore, you must put your hat thinking what that something else might be to know what antibiotic you're going to prescribe for that individual. The lady comes in, she's having some GYN issues that you suspect could be an infection, but you know your patient. The patient has severe leukopenia, okay? It is your job as a journalist. Yes, you could send the patient to the GYN to do a proper pelvic exam, which I don't do, but don't expect the GYN doctor to know this stuff. That's nothing wrong with her. She or he is pretty smart, but he or she is not general internist, which is associated more with infectious diseases than this lady is. Let me give you an example to make you laugh. When I wrote my first book, very first book, 1992, I was so upset the way ladies were being treated by the gynecologist. I wrote a section in the book that was brutally negative toward these people because I didn't appreciate the way they were treating ladies. It so happened that the book was sent for review, and the book was got into the hand of a GYN doctor at Downstate Medical School. But however, prior to getting there, the publisher said, Dr. Alcena, you can't say these things. They may be real, and I don't doubt you, but you can't say these things. Please give me permission to delete those sections. I said, please go right ahead and do that, because you know more about book writing than I do. Little do I know that this same book was going to be reviewed, had nothing to do with it, was going to be reviewed by a GYN doctor at Downstate Medical School. This man thought this book was the best book since the world created. And he gave my book this huge and incredible positive report And that launched my writing career. And if this poor guy had seen what I had written, he would have taken the book and thrown it in the garbage. Okay? So you got to be careful what you say. Keep your mouth shut. Silence is power. Okay? So this is a classic example. This man, to this day, unfortunately he passed away, thought I was the greatest thing since God knows what, apple pie. This was my very first book. That evaluation of that book sort of really propelled my writing career as it is today, 28 books, 27 books later. Okay? So you got to be careful. Keep your mouth shut. Do what you have to do, but don't go about and criticizing people. I learned my lesson. Okay? So therefore, then, the patient may have sarcoidosis. Sarcoidosis can be associated with low white blood cell count. My first exposure to sarcoidosis, I was a third-year medical student at Einstein going to a radiology elective at Montefiore. I knew nothing about anything. It was my first week, my first day, as a matter of fact, on the radiology department. There was a guy named famous radiologist from India who used to come and spend 6 months in the radiology department. He used to write a column on the JAMA, blah, blah, blah. And he used to put out cases outside. There was one case out there, you could read it. If you know what it is, put your answer and then dump it in the thing. Dump it in the box. I know nothing. All I know is that this was my first week, my first day, and I look at it. His name was Subi. This is not a real name, but it was Subi. And I put down sarcoidosis and dump. This thing has been there for several weeks, several months. Nobody can get it. I know nothing about it. I put a 4x4 card from my pocket. I write sarcoidosis. When you look at the history, this patient had low white blood cell count, but the x-rays were bone x-rays. Little do I know nothing about sarcoidosis, but the low white blood cell count give me a tip that could be sarcoidosis. Sure enough, it turns out to be sarcoidosis. Okay? And the radiology department to this day, they thought I was God gift to the world. I get an honor for the course. I know nothing about sarcoidosis, but the leukocytosis helped me. And I wrote that and dumped it in the box. It turns out to have been sarcoidosis. How about that? That thing was there for months. Every day people are passing by, looking at it, reading it. Me, I know nothing about that. This is my first week there. I'm just taking a radiology elective. All I know, I see the white blood cell was low. It was about 3,000 or less than that. I think, now, wait a minute. What to prevent this from being sarcoidosis? Guess what? It was sarcoidosis. Okay? And then I could do no wrong for the rest of the 2 months or so. I was an elective at the radiology department at Montefiore. Listen, I'm going to stop here until I see you again. This is Dr. Alcena saying so long and bye-bye.